Hello everyone, today we are going to discuss another set of one-liners and MCQs in relation to pediatrics. To start, when to stop a rescuscitation as per latest NRP guideline 2020. Confirmed absence of heart rate after all appropriate steps performed for how many minutes? Is it 10 minutes, 15, 20 or 30 minutes? What is the answer? A, B, C or D? As per latest NRP guidelines, the answer is 20 minutes. Previously, as per 2015 NRP guidelines, it was 10 minutes. So now they have changed it to 20 minutes. So as per recent guideline, we have to stop resuscitation after 20 minutes. Second, 5-year-old child having karyotype XY presented with precocious puberty with blood pressure to 126/86. What is the deficiency? What is the thing to be marked here? It is the karyotype is XY. XY means this is a boy child presented with precocious puberty, means testosterone level is high with hypertension as blood pressure is 126/86. So with these three, boy with hypertestosterone level with hypertension, then what is the deficiency? Is it 21 hydroxylase or 11 hydroxylase or 17 or both A and C? The answer is 11 hydroxylase deficiency. So we can look at this chart where we can know that the cholesterol, it is getting converted to your pregnenolone to 17 hydroxy pregnenolone, that will convert to your dehydroepiandrosterone, androsterone and testosterone. All these will be found that enzyme responsible is 17 hydroxylase, and pregnenolone with the help of your 3-beta dehydrogenase, it will convert to your progesterone. Again progesterone with 21 hydroxylase, it will convert to deoxycorticosterone, and finally it will convert to your aldosterone. So one path is your pregnenolone progesterone, that is forming your aldosterone. Another path is your 17 hydroxy pregnenolone, that is converted to your cortisol. And final pathway, dehydroepiandrosterone. So there are three lines. We can see that 17 hydroxylase is responsible for the forward that towards the formation of your dehydroepiandrosterone. Ultimately, that is forming your testosterone. Similarly, in this case, your then what is the deficiency? Where you will get more testosterone level and more action of your mineral corticosteroid, that is your aldosterone level. Then deficiency is your 11 hydroxylase. Your 11 hydroxylase deficiency, that will cause less synthesis of your cortisol, but that will cause more formation of your mineral corticoid and your testosterone. So any boy child with features of hypertestosterone level with hypertension, your diagnosis is due to deficiency of 11 hydroxylase. Similarly, another question, that same boy child with precocious puberty but blood pressure is normal tension, then what is the diagnosis? Diagnosis is your 21 hydroxylase deficiency. Here we can see that if 21 hydroxylase deficiency is there, then there will be no formation of aldosterone, no formation of cortisol. So all the precocious, that will be converted to your testosterone level. So there will be features of hypertestosterone level, but aldosterone level will be low and cortisol level will be low. So the answer is precocious puberty with normal tension, that is your 21 hydroxylase deficiency. If it is a hypertension there, then that is 11 hydroxylase deficiency. Another, suppose a girl child with normal genitalia and hypertension. Hypertension is there means your aldosterone level is high. Normal genitalia means your testosterone level is normal. So what is the deficiency? Deficiency is your 17 hydroxylase. We can see here 17 hydroxylase, that is responsible for your formation of more formation of your formation of cortisol and testosterone. But here girl child, 17 hydroxylase is deficient, so your aldosterone level will be high. So your features of hypertension will be there, but there will be no features of hypertestosteronemia. So this is a normal child with features of hypertension, any girl child, then your deficiency is 17 hydroxylase. So these three we have to remember. We can get one MCQ in exam. Cyanotic child with increased pulmonary blood flow with wide and fixed second heart sound. What is the diagnosis? At a look, suppose there is pulmonary blood flow is more, wide and fixed means there is one in our mind, that is your ASD. Then what is the diagnosis? Is it ostium primum ASD, ostium secundum, tricuspid ataxia, or TPVC? As because it is a cyanotic child with pulmonary plethora or increased blood flow with features of a ASD, the diagnosis is TAPVC. This we have to remember. This is one clue. Any child in the neonatal period or in the early infancy, features of a ASD with cyanosis, diagnosis TAPVC or total anomalous pulmonary venous connection. Any acyanotic child with features of ASD, the diagnosis is ostium primum A. Diagnosis is ASD. Suppose there is a left axis deviation, then that is ostium primum ASD. Cyanotic child with features of ASD, that is wide and fixed S2 with increased pulmonary blood flow, diagnosis TAPVC. Same cyanotic heart disease with increased pulmonary blood flow but left axis deviation, then the diagnosis tricuspid ataxia. So the examiner may put the question like that: with features of left axis deviation, then the answer would be tricuspid ataxia. With features of ASD, cyanotic heart disease, increased pulmonary blood flow, then the answer is TAPVC. As cyanotic heart disease with features of ASD, that is with left axis deviation, that is the answer is ostium primum type of ASD. Friedrich's ataxia is due to defective triple codon repeater. Where is the defect lines? That is the CTG or CGG or GAA or CAG. The answer is GAA. So we can remember some more things like your myotonic muscular dystrophy. The defect is at the level of CTG. Friedrich syndrome, your CGG. Huntington's chorea, your CAG. So we can remember MF Hussein. M means myotonic muscular dystrophy. F means Friedrich syndrome. Hussein means Huntington's chorea. MF Hussein, your deficiency will be CG will be constant, but in between the defect will be TGA. T CTG for M, that is myotonic muscular dystrophy. TGA, G for Friedrich syndrome, and Huntington's chorea for TGA, that is CAG. This the mnemonic that we can remember for so that we will not forget. All are features of Friedrich's ataxia except. Is it loss of vibration? Which one is not correct? Rhombus is positive, deep tendon reflex is absent, and plantar response is flexor. Which among the four is not true? The answer is plantar response is flexor. This is not true. The plantar response is always extensor. Some more lines, few words. Friedrich's ataxia is autosomal recessive type of inheritance. Mutation in FXN gene on chromosome 9. Mainly involves dorsal column, pyramidal tract, and spinocerebellar tract. This you have to remember. Posterior column, pyramidal tract, and spinocerebellar tract. Accordingly, you will get all the clinical features. Features of your ataxia, your positive number test, all these are features of your cerebral tract involvement, extensor plantar because of your pyramidal tract involvement, your absent DTR, loss of position and vibration with normal intelligence. Here what we will get? We will get intelligence will be normal. Your posterior column, as because posterior column is affected, so your loss of position or vibration sensation will be there. What extra finding we will get? We will get pes cavus, hamartosis, and kyphoscoliosis. And what is the cause of death? Cause of death is your HOCM. HOCM leading to your CCM is the cause of death in case of Friedrich's ataxia. So you can remember it is chromosome number 9 is responsible for your Friedrich's ataxia, mutation in FXN gene, and it is autosomal recessive type of Mendelian inheritance. Next, 11-month-old baby with recurrent bloody stool, atopic dermatitis, having TPC 20,000. Next test to establish the diagnosis. First we have to think What is that? What could be the diagnosis? It is the 11-month-old baby with recurrent bloody stool. Atopic dermatitis, that is also important. Atopic dermatitis with thrombocytopenia. What is the diagnosis? Diagnosis is what is coming to our mind. As because atopic dermatitis eczema is there, so it could be a case of Wiskott-Aldrich syndrome. So check for antiplatelet antibody, thinking to be a case of ITP. So now how you get atopic dermatitis? Bone marrow aspiration to establish a diagnosis of your ITP. Screen for WASP gene, WASP gene expression. This is the right answer. Because we are suspecting this could be a case of Wiskott-Aldrich syndrome. This is X-linked recessive, defect in WASP gene on X chromosome. It's a triad of eczema, thrombocytopenia, and a recurrent infection. What you will get immunologically? You will get low IgM. This we have to remember. WASP, Wiskott-Aldrich. It contains W, so it is related to just opposite of W, that is M. Low IgM and increase in IgA and IgE. This we can get another MCQ. So low IgM with increased IgA and IgE and triad of eczema, thrombocytopenia, and a recurrent infection. Next, in neonatal resuscitation, which of the following is the most effective indicator of successful ventilatory effort? Is it color change? Is it rise in heart rate? Is it chest movement or chest rise? The most sensitive indicator is your rise in heart rate. Next, 7-year-old boy presented with fatigue, muscle and joint pain for last few months. On examination, the following rash is noted. Look at the rashes at the dorsum of the hand. What is the possible diagnosis? First, we have to think what is these rashes. These are croton papules. So, what is the diagnosis? Diagnosis is very simple. That is juvenile dermatomyositis. What we will get in juvenile dermatomyositis? We will get the classic rash, that is the heliotrope rash of the eyelids. This is the classical heliotrope rash around the eyelids. This is the croton papules. This we will get in juvenile dermatomyositis. And what else? Along with that, we will get, to establish a diagnosis of juvenile dermatomyositis, we have to get heliotrope rash of eyelids and croton papule. Along with that, three of the following. What are the criteria? Symmetric proximal weakness, one. Second is your elevated muscle enzymes, your creatine kinase, your LDS, aldolase, all these electromyographic changes, and fourth is your muscle biopsy suggestive of necrosis and inflammation. These are the things. Among the four, we have to get three plus your classic rashes that will tell that we are dealing with a case of juvenile dermatomyositis. This is the classical picture of your heliotrope rash and your croton papules. Which type of voluntary disease is autosomal recessive? Is it 1, 2A, 2B or 3? The answer is 3. Type 1 and type 2 all are autosomal dominant type. Your type 3 is autosomal recessive type, where you will get no level of your absence of your voluntary factor, total absence. Your type 1 will get minimum some deficiency of voluntary factor. Type 2 is your qualitative defect in your voluntary factor, but type 3 is your total absent, and this is the inheritance is your autosomal recessive type. Next, 18-year-old boy admitted with complaint of delayed puberty. On examination, he is tall, underweight, having large arm span and small testis. Had a history of antisocial behavior during school days. Most probable diagnosis. What are the things you are getting? Features of delayed puberty. First, second is tall, with arm span, large arm span is more than your head to toe. Your arm span is more. Testis is small and with history of antisocial behavior. What is the diagnosis? Is it William? Is it Noonan? It is Klinefelter or Marfan? The answer is Klinefelter syndrome. The Klinefelter syndrome, something to clinically what will you get? We will get frontal baldness, your sparse beard growth, all features of hypoandrogenemia will get. We will get gynecomastia, estrogen level will be high, gynecomastia will get around 30% cases, arm span is greater than your height, feminine distribution of your pubic hair, small penis, small and firm testis, all these things will get in the case of Klinefelter syndrome. Karyotypic wise will get 47XXY. Your total karyotypic will get XSY will be XSY, that is 47XSY. Clinical feature wise will get infertility, small testis, and elevated gonadotropin levels around 90 to 100% cases. Other features like decreased testosterone, decreased facial hair, gynecomastia around 60 to 70%, pubic hair, decreased pubic hair, and penis size around 20 to 30% will get. So this is a case of Klinefelter syndrome. Thank you. Please like this video, share this video, and subscribe to my channel. Thank you.